Okay, as Dr. Katz already referred to and Colleen just described, there's mounting evidence for this combined benefit of being medically optimized on medication and exercise. So we're going to get that discussion going full blast and talk about some of the specific research associated with exercise changes. So just putting the exercise research in context, in a general sense, physical therapy intervention, exercise with individuals with Parkinson's disease has been dramatically impacted by the work that we've done and the work that other people have been doing. And some of those dramatic changes are people with Parkinson's disease are seen earlier. It used to be that there weren't referrals to physical therapy until people were at very severe stages of the disease, and a lot of the physical therapy intervention would be about training the caregivers. The training itself is much more intensive than it used to be. I remember when I started my postdoc and started this research in exercise in a mouse model of Parkinson's disease, I did a search of the literature and found that over a 50-year period, the exercise studies in Parkinson's disease were very, very minimally challenging types of intervention, stretching and things like this. But now the training is much more intensive. And there is a change in the emphasis. The emphasis is on challenging impaired systems rather than compensation, rather than necessarily just helping people adjust as they inevitably decline, which is the way it used to be considered. So there is definitely a new awareness of the benefits of exercise. But as I talk about these things at meetings like the Society for Neuroscience meeting, the kinds of things I hear are from scientists and physicians are, well, it's not a cure. And the second thing is, but the benefits only last as long as exercise continues. And I'm always sort of puzzled by that one, because it's pretty much true for everyone, isn't it? And for example, there's no cure for aging, not any that I've found anyway. But we know, based on the literature, there are tremendous exercise-induced benefits on age-related declines. And the other thing we know is that individuals, older individuals, younger individuals, need to keep exercising to attain or maintain those benefits. So if we just look at something like a figure like this, where we can see the change in function over age, over years, we see a natural decline in functional ability. But what we have seen through the literature in aging research is that essentially we can absolutely impact the rate of that decline and maybe even reverse it. Okay. Now, the benefits of exercise, we know, occur in part through neuroplasticity. Specifically, experience-dependent neuroplasticity. So what's that? It is the brain's ability to reorganize itself by forming new neural connections throughout life in response to experience, in response to what you do. It involves synaptic restructuring, both morphologically and functionally. So there's changes in the connections that are made in the brain. Experience-dependent plasticity essentially refers to mechanisms by which the brain encodes experience and learns new behaviors, and also refers to mechanisms by which the damaged brain relearns lost behavior in response to rehabilitation. And the really exciting, wonderful thing is these exercise benefits extend to individuals with Parkinson's disease. And I came in my clinical years from a stroke model, in which stroke is characterized by a single event, and we could see that there was a lot of recovery, huge recovery potential and neuroplastic changes. But we now know that even in a degenerative process that there are these benefits as well. So I want to orient you to this figure to point out the sort of important players in this story. This is very simplistic, but overall will help us make the point. So we basically have, as Dr. Katz talked about, the place where dopamine is produced, and then from there, this pathway from the substantia nigra to the striatum. The nigrostriatal path is where dopamine is carried to the striatum, which is essentially a part of the basal ganglia, an important kind of way station for the basal ganglia. And in that area, in the basal ganglia, are medium spiny neurons. Basically, those are the key players, the key neurons in the basal ganglia. Represents approximately 96% of the neurons within the basal ganglia. So the other really important connection, I mean, again, very simplistic, is then this area's connection to the cortex. And particularly what we're looking at here is the cortical striatal pathway, which uses glutamate as the neurotransmitter. Okay? Hopefully this will all become clear. What I want to point out again, as Dr. Katz discussed, is this is where dopamine is manufactured, but this, in the striatum, in the basal ganglia, in the cortex, this is where dopamine is used. And so while dopamine levels are diminished in Parkinson's disease, key problems result from the fact that dopamine is not as available to modulate glutamate in the cortex, with the end result of what we know as cortical hyperexcitability. And we have demonstrated, we know from other research, that increased excitability in the cortex in the brain of people with Parkinson's disease is related to severity of Parkinson's disease symptoms. So what you're looking at here on the y-axis is the Unified Parkinson's Disease Rating Scale, which you've all probably been through with, or a number of you have been through with the neurologist asking you to open and close your hand quickly, things like that, yes? And we know that the higher the number, the more severe the symptoms. What you're looking at here is that there was a very clear association between a higher number in terms of disease severity and a higher excitability in the brain. So these were very much connected. So to summarize, and I'm just going to read this slide, Parkinson's disease is a problem of dopamine neurotransmission that results in corticostriatal glutamatergic hyperexcitability. Now, there is compelling evidence that this hyperexcitable state underlies the very motor dysfunction associated with Parkinson's disease, including gait and balance impairments, slowness, and stiffness. So when you consider Parkinson's disease from the perspective of these downstream changes and effects in the effects on the cortex, in addition to dopamine cell loss, you add this idea to your arsenal. And I think if you understand Parkinson's disease from this perspective, as opposed to only dopamine-producing cell death, then presumably more therapeutic targets are revealed. Okay? So the question is, what if physical therapy, what if exercise could reverse the hyperexcitable state? And overall, there is no evidence in our work that exercise increases the amount of dopamine or increases the number of dopamine-producing cells. And you might think, well, that's not good news. But what we are finding, both in animal models and in humans, is that exercise affects how dopamine is being used and causes changes in the circuitry in that area that decrease the hyperexcitability of the system. And overall, we have a happy face. You guys with me? Okay. So far, what we know and continue to study are that two key ingredients for facilitating neuroplasticity and behavioral recovery, two key ingredients of an exercise program are these: goal-directed motor skill training and aerobic exercise. Both of those seem to be really powerful key ingredients of any exercise program to facilitate the kind of brain circuitry changes that are important for decreasing this hyperexcitable state and improving behavior. And we discussed this really a lot in detail in a paper we wrote, a review paper. And the data in general support that exercise paradigms that incorporate both goal-directed practice and aerobic training may work together to facilitate neuroplasticity necessary for overcoming this aberrant circuitry problems in the basal ganglia and cortex. So you can see here we have exercise, goal-directed motor learning, aerobic exercise, both aspects, and inducing changes in general brain health, and then as well as these very specific circuitry changes. So I want to highlight work related to two exercise paradigms that include these two ingredients. That both of these exercise paradigms have both the aerobic component as well as the skill-based component, but most importantly, because so many exercise have both components, the reason why I'm highlighting these is well, it's our research, so I definitely want to talk about that. No, the key thing is that both of these areas of research have demonstrated brain changes, neuroplastic changes, which is essentially what I want to talk to you about. So our studies, I want to describe our studies, and I'm going to flip a little bit between the mouse, the work we've shown in the mouse model, as well as in the human trials. There's certain limitations in our human trials. You know, people just get upset when you take their skull off, and you know, they don't want you removing their brain, and you know, so there's a lot of things we can do with a mouse model that clearly you cannot do with the human. You know, IRB just won't let you do that in your study. But we have at USC, I feel really pleased about the fact that we are truly a translational model. And oftentimes at universities where people are studying Parkinson's disease, and there's a group that's doing animal model research, and then there's a group doing, you know, human trials, they don't really communicate. We, almost in real time, go back and forth between what we find in our animal model and what we find, and then we translate that to the human and back and forth. I don't know why that's so dark, but and you can't see it, I don't think, because it's too dark, but we have we are very, very, we care about the confidentiality of all of our subjects, so. Okay, so in our mouse model, Parkinson's disease is modeled in rodents by injections of neurotoxins, such as MPTP, 6-hydroxydopamine, and what those neurotoxins do is selectively target dopamine-producing neurons in the substantia nigra pars compacta, and they result in loss of dopamine-producing neurons, 60 to 80% loss of striatal dopamine, and looking something like a Parkinson's situation. So when I was a postdoc, this is what I established as our exercise paradigm. We essentially used treadmill training, and we would start with our mouse and see if they could run, basically. And then the mouse groups were then split into those that were injected with the neurotoxin and those that were not, that were injected with a saline compound that didn't change the brain. And then we further divided those animals into saline-injected exercise and saline-injected no exercise, MPTP injected exercise, and MPTP injected but no exercise. Does that make sense? Okay. And this is one of our great videos. Can you guys see it? It's kind of dark. Can we change that or fix that? I don't think we can see it at all, really. I don't know why. Anyway, what you can see, sort of, yes, is right here. This is our, I'll play it again. This is our MPTP, our animal that had exercise. This is the MPTP animal that did not have exercise. And he's just trying to get on the treadmill, and he keeps sliding back and slipping off. Usually when I show this with therapists, they're like jumping up. They want to help this little guy so much. But essentially what we see is that we very much, just with the practice of running and doing the treadmill training, we see this big difference in how they behave. Okay? Sorry, that was a little... As I said, Parkinson's disease is a problem of dopamine neurotransmission that leads to corticostriatal glutamatergic hyperexcitability. So we want to focus on the exercise effects on that hyperexcitable state, the things that we've seen, not in the area where dopamine is produced, as I said, but more what's happening here, okay? And I've taken this kind of larger section, and we're going to look at this with a little bit finer lens. And you can think about this neuron, this dopamine-producing neuron, is connecting here on the medium spiny neuron in the basal ganglia. And we're also going to look at this connection, the connection between the medium spiny neuron and the glutamatergic neuron. Okay, does that flow pretty well? Okay, so now let's talk about the brain changes that go with those behavioral changes that you saw. This is the medium spiny neuron, and it's called the medium spiny neuron because you see millions of these dendritic spines on the neuron. Millions of them. Very spiny, okay? That's where all the connections are made in the brain. That is where it's on those dendritic spines that all the decisions are made to build the scaffolding, to form a new connection with another part of the brain. And what we want to look at is first talk about the exercise effect on those spines, of the basal ganglia neurons. And what we find is exercise helps connections of brain cells. So this is some research that we did in our lab, and what you're looking at is basically, here's our saline group, here's our saline plus exercise group, and what I want you to notice with this high resolution is look at all those dendritic spines. You can see all those connections here. But what happens with MPTP? We lose spines. We lose those connections. So, as you know, Dr. Katz said, that's a key part of what dopamine is doing, is it's modulating some activity related to the connection. And if we don't have the connection, it can't do its job, even if it is, even if there is some deficient amount. Here's the exciting thing. With exercise, we see an increase in dendritic spines, a significant increase. If you look at here, this graph, this basically, the groups you're looking at here are the white bar is saline. This is saline plus exercise. So we see an increase in dendritic spine number just with exercise itself. But look at what happens with MPTP, with the neurotoxin that decreases dopamine. We see this effect on spine loss. And then with exercise, we regain those spines, regain the ability to form connections. Okay? You all with me? Okay. I have found in discussing this work with people with Parkinson's disease is a very sophisticated group, very interested in knowing a lot of the details associated with, some of these molecular changes. And so please let me know if you're hanging in there or need me to explain something a little bit better. Again, I'm just kind of picking and choosing some of the things that we've seen, because another thing that we have seen is an exercise effect on the receptor, the D2 receptor, dopamine receptor, on the medium spiny neuron. So if I'm bringing dopamine to the cell, it's the receptor essentially that's picking that up, okay? And what we have seen in our mouse model, and this was using a PET imaging, this was a PET imaging study with the mouse. I know it seems ironic that it's called PET imaging and we're using a mouse, but this basically was a really nice segue to a human trial in which we did the same thing. We used a specific radioactive ligand for the D2 receptor, and we looked at what happened with the saline group. You can see that bright red basically establishes that there's a high binding potential with respect to this D2 receptor. And we see the same thing with saline plus exercise. Look at the MPTP group. It's basically gone, saying that the receptor on that medium spiny neuron, that part of the neuron that enables dopamine to basically impact the information that's being processed, we don't see any, okay? Look what happens with exercise. And you can see the result here. We show, again, the black bars, the MPTP groups. This is our no exercise group. With exercise, we see an increase in the D2 receptor number. Okay? Last thing is that we also see a change in the connection that I talked about from that medium spiny neuron to the glutamatergic neuron from the cortex and to the cortex. Okay, and we're talking about these receptors here on the medium spiny neuron, the receptors that basically process glutamate. And what we find, which is very exciting, I'll orient you a little bit to this, is that exercise changes the glutamate receptors on the medium spiny neuron from a type that are highly, highly excitable to a type that is very low excitability. And you can see that here. We have the highly excitable, what are called GLU-A1 receptors with MPTP, but then with exercise, we get a greater increase in the low calcium permeable, low excitable GLU-A2 receptors. So we're changing receptors on that medium spiny neuron, both the dopaminergic pathway and the glutamatergic pathway. And essentially, this is what we find is this exercise change in this AMPA receptor, glutamatergic receptors. The ratio is to less excitable, okay? So now let's switch to our human trials and talk about, again, some of the way that we've been able to translate this data to the human condition. We've had, I'm going to talk about 2 trials only that we've done. Both are with people that are early with respect to diagnosis. Within 3 years of diagnosis is the first trial. And then the second trial was one in which people were within 1 year of diagnosis and not on any medication at all, because that was our PET imaging study and we didn't want to have any confounds with drug. What we utilized as our intervention was, as I said, this combination. The high-intensity aerobic piece was treadmill exercise, and all of the subjects in the study were to achieve a target heart rate of 75 to 80% of their maximum. And the treadmill velocity required an effort of, at a minimum, of 3.5 METs, or metabolic expenditure. And that was for 60 minutes on the treadmill. The motor skill part of it was that we didn't just crank up the speed on the treadmill and let people drag, across it. Is that we had a stipulation that the individuals in the study would walk with an observationally normal gait or running pattern. And feedback was provided regarding alignment and gait kinematics, and so people were having to process information regarding the skill. And that was compared to low intensity, which was, as I mentioned before, sort of a composite of some of the research that I had seen in the literature, with some passive range of motion, some balance activities, but overall very minimally challenging. And the heart rate level was like 50% of target heart rate, or 50% of maximum heart rate. And we also then compared that to a no exercise group, which the unfortunate thing at the time is that for people within 3 years of diagnosis or within 1 year of diagnosis, no exercise was standard of care. I mean, essentially, this has all changed in an exciting way, but at the time, we were able to get away with a no exercise group. So I'm excited particularly about the exercise performance changes that we saw in our high intensity group. And we had people that were in their late 70s. We had people that ranged from 40 years old to 80. But we had people basically running on the treadmill. And so over the 24 exercise sessions, the high intensity exercise group worked on an average at a MET level of 4.3 with a range between 2.5 and 13.3 METs. 60% of the high intensity exercise subjects achieved that MET level while running at 0% grade and speeds ranging from 5 to 8 miles per hour on the treadmill. I can't run 8 miles per hour on the treadmill. And just to show you, I hope it shows, but just a little bit of an example of one of our subjects. You can see him starting out on the treadmill and walking, and again, there's a therapist there who's giving him a lot of feedback about his alignment, arm swing, movement in general. Again, really going for an observationally normal pattern of walking. And then you can see the speed of the treadmills increasing. And now he's running. And then just to show you that there were some other more, kind of cognitively challenging, motor cognitive challenging tasks with respect to stepping backwards and some other aspects to this. So what did we see? And again, I selected things that really paralleled our animal research. We did a PET imaging study with a small group of subjects. PET imaging is extremely expensive, and so we were only able to really do a pilot project with this, although we did get this published because I think our results were really above the noise level here. We had 2 individuals with Parkinson's disease that exercised intensely, like you saw. We had this was I apologize. This was the study in which the subjects were within 1 year of diagnosis on no meds, because we were using this F18 thalapride ligand to look at the binding potential of the D2 receptor. And here are the Parkinson's subjects that had no exercise, and this was our one healthy control subject. We had 2, but we were only able to get the data from 1. But the key thing that I want you to see here is you're looking at pre is the light red, post is the dark red, and in our subjects we saw a 98% increase in one subject and an 81% increase in the D2 receptor binding potential, suggesting again that we see this increase in the D2 receptors. In our individuals who didn't exercise, no change, and then overall not a real change with our healthy control, but a higher level to begin with. Okay, so going on with the connection between what we've seen in mouse to human, how can we assess excitability in the human brain? And can we then determine whether cortical hyperexcitability has been reduced with exercise in people with Parkinson's disease? We use something called transcranial magnetic stimulation. How many have heard of that? Okay. All right. And I'm not going to go into a lot of details, except basically you're stimulating from the cortex, for example, and you're able to look at the excitability by looking at the EMG output from a specific muscle. So you're stimulating over the representational area in the brain of that muscle, and you're recording out here in the periphery. And this is a TMS coil, and we stimulate and then get this readout of excitability. One measure being this motor evoked potential. So this is actually where the stimulation occurs, that red line, and then the green marks the beginning of the evoked potential from the stimulation. Now, another measure that you can get using TMS, another measure you can get using TMS that reflects this excitability is something called the silent period duration. So you see your motor evoked potential, and it's followed by EMG silence. Okay, the cortical silent period duration. And what we know is that the duration of this silent period is a measure of inhibitory circuits. So in Parkinson's disease, the most common thing that is seen in using TMS is a shortened silent period duration, which reflects hyperexcitability. Because if I have less inhibition, I have greater excitability. Does that make sense? So, and that basically is what we're saying here. Shortened silent period durations are among the most consistent and widely produced TMS finding among Parkinson's patients. Symptomatic treatment of Parkinson's disease with surgical or pharmacological interventions is associated with lengthening of the cortical silent period. The thing I want to point out to you is that every single one of our patients that got the high intensity exercise had an increase in their silent period duration using TMS. So again, decreased excitability. So if we put all of our findings together, Parkinson's disease, a problem of dopamine neurotransmission that results in cortical striatal glutamatergic hyperexcitability. Exercise impacts this problem by releasing dopamine more readily and keeping it out in the synapse. With this low dopamine signal, increase the antenna by increasing dopamine D2 receptors on the medium spiny neurons. And thus you're improving this modulation of glutamate. We also saw this replacing highly excitable, the glutamate receptors with low excitable glutamate receptors. Overall, hyperexcitability diminished. And again, not our mice, but if you can see, this is a patient pre and post 12 sessions walking out of the same area. This is a case study that was done by one of our team, Dr. Claire McLean, and looking at the impact of intensive physical therapy. Okay. Pretty exciting, right? I mean, he's like all the way to his car and he's still just getting out the door here. I know that, so you get the idea. Dr. Cottle actually is going to talk about the other research that's been done a little bit. But again, it's just thinking about there's some brain measures associated with this research showing improvement in dopamine use, but it's with cycling, a cycling study, okay? So bottom line is, what we've seen is goal-directed motor skill training in people with Parkinson's disease, Tai Chi, boxing, tango dancing, amplitude training. We've seen benefits of exercise with all of these things. And again, I think what they all have in common is that they are basically utilizing both a goal-based practice as well as some cardiovascular fitness. So that always brings up the question then, what exercise should I be doing, right? Is that what you're thinking? And as Dr. Katz said, whatever you like, whatever you love doing, and whatever you can progress in terms of the challenge level. That is really what's important. What are you going to stay committed to? Because this is what we're talking about is a lifelong commitment to exercise. And I just want to finish with a couple of things here. Because if I were to ask you what you think is the primary reason people with Parkinson's disease do not participate in exercise programs, what do you think would be the reason that's been identified? Balance, motor problems. You know what it is? Self-efficacy. Those people with Parkinson's disease with high self-efficacy were more than twice as likely to engage in exercise as those with low self-efficacy. So that is really a key aspect of engaging in an exercise program. And I think, seeing a physical therapist, working with a trainer, building that confidence, and then going on from there, I think is really critical. The other thing, last thing, I think this is kind of a fun, what this paper talks about is factors that influence physicians and medical students' confidence in counseling patients about physical activity. Basically, what they discovered was that physicians and medical students who met vigorous Department of Health and Human Services guidelines for exercise were more likely to then refer people for exercise. And just to show you that I put my money where my mouth is, I'm very proud of that shiner. I probably hit myself with my boxing glove. I think you do whatever exercise you love to do, that's what you stay committed, but I actually happen to love boxing, so. Pretty good for an old person, right? So again, take-home points, exercise is important for brain health in individuals with Parkinson's, not just medications. Exercise that incorporates challenge and skill task practice facilitates beneficial neuroplastic changes in basal ganglia cortical circuitry. Exercise that incorporates aerobic practice may be important for facilitating the brain environment necessary for those circuitry changes. And the last thing, enjoy. We are more likely to stay committed to our exercise program if we like what we're doing. And our critical future question that we are looking into and studying now is, can we actually change the progression, modulate disease progression through exercise-induced neuroplasticity? So our funding sources, recently National Parkinson Foundation, we're studying sort of the combined effects, the separate but combined effects of strictly aerobic training with skill-based training, and just some important members of our team, one of which you'll hear from shortly, Dr. Erin Cottle. So thank you very much. Sorry for a lot of